Desai, it's all
Thank you,
yours.
Colin. Yeah, thank you. All right, next slide. So financial disclosures, nothing of relevance. I don't intend to discuss any off-label use or investigative use of any commercial products or devices. Next. So these are the disclosures that we've talked about. By the way, I apologize for if there's a notification ping that comes up. So today's learning objectives are that we are going to focus on prevention of dementia, new revised criteria for Alzheimer's disease, then the role of biomarkers in early accurate diagnosis of Alzheimer's disease, so not other dementias, and to discuss new FDA-approved medications for Alzheimer's disease in clinical care, specifically on the anti-amyloid therapies. Next slide. So let me give you a case. So the grandson came with his grandfather, who is 88 years old, for me to help with the management of agitation and insomnia. But during the visit, he also mentioned that his father, he has noticed, is having, quote, a lot of forgetfulness, end of quote. And he's wondering whether he could be having a start of Alzheimer's disease. Next slide. So I told him that, your grandfather is one of 7.2 million Americans who have dementia, and he's amongst 12 million family caregivers, family care partners. That although Alzheimer's disease, dementia account for 60 to 80% of dementias, we need to realize that 50% or more have mixed dementia. So it's quite likely that his grandfather probably has mixed dementia, both Alzheimer's disease and vascular dementia. And also, most of the individuals with Lewy body dementia have Alzheimer's disease neuropathology. Next slide. Uh, One of the discussions we had was dementia prevention. So, for example, if his father is having slight memory problems, forgetfulness, what can be done so that he prevents dementia that his grandfather has developed? The grandfather is in moderate stages, and then he's worried about himself also. So I said that there is a huge paradigm shift in our understanding of dementia prevention, and now we have solid research to say that 45% of dementias are preventable, and I'll explain what that word means. And also, there are 14 modifiable risk factors for dementia that have been established. There's a good chance we'll see more coming up. And all this also helps us understand that there are unmodifiable risk factors. So, age would be the biggest. By the age of 88 years old, at least 1 out of 3 individuals will develop dementia. So age is a big risk factor. And then genetics. So if his grandfather has ApoE4 gene, then again, that puts him at higher risk of developing Alzheimer's dementia. Next slide. So again, the way to understand these modifiable risk factors is like, let's say today is September 9th. So let's say in the next 4 months, we eliminate all these modifiable risk factors. Then in the year 2026, 45% less people will develop dementia. So on average, 10 million individuals every year develop dementia. So theoretically, all right, 4.5 million individuals will not develop dementia if all these modifiable risk factors are eliminated. So everybody gets secondary education, nobody has social isolation, there's no air pollution. We've fixed everybody's visual loss. Next slide. We've fixed hearing loss, fixed low density lipoprotein that's elevated, no depression, nobody gets TBI, hypertension, diabetes, smoking, physical inactivity, obesity, excessive alcohol. So if we fix all this, then one's future risk of dementia will dramatically go down if we have these modifiable risk factors. Next slide. Again, if we want a specific resource than improving brain health is an ebook that's available on our website in both English and Spanish, and blogs and podcasts are available. So, when it comes to practical benefits of these modifiable risk factor treatment, I would say that for that grandson, that I would have your father come to our clinic, get comprehensive assessment, and then yeah, we can work with him to improve his brain health by addressing all the modifiable risk factors that your father may have, so that there is reduced risk of him developing dementia in the future. Another definition is that one may develop dementia, but you push it back. So instead of developing it in the next 2 years, you develop it after 5 years. So that's again, we are preventing dementia. That's another definition. And same thing would apply to the grandson. If he's interested, then we can assess his modifiable risk factors if he has any, and we would address it. And we would create a brain health program for him that is individualized, and that in turn would help him do the best he can to prevent future dementia. Next slide. So the next uh, focus is on sharing these new revised criteria for diagnosing Alzheimer's. So in the past, the diagnosis was clinical, but most, not all, most researchers now feel that we should diagnose Alzheimer's disease biologically. So if you have biomarkers, then you have Alzheimer's disease, and then you can decide whether you have clinical manifestations or not. So they have also proposed biological staging. So biological staging is different than clinical staging. So it's important to understand this because in the past, let's say the grandfather could be diagnosed with Alzheimer's dementia, but his son, who might have some memory problems, but let's say he doesn't meet the criteria for dementia, then we would not say that he has Alzheimer's disease. But now, with this new definition, if I do biomarker testing, and we'll talk about it, then I could say that your father has Alzheimer's disease in the brain. Doesn't mean that he'll necessarily develop cognitive decline, but there is a high likelihood that he will, and we need to do something about it. Next slide. Again, before I go to this slide, many researchers, especially in Europe, don't agree with this biological definition of Alzheimer's disease. That's changed. So just for you guys to know. So now we'll have biomarkers. So there are core 1 biomarkers. We need that to make a diagnosis of Alzheimer's disease, and then core 2 biomarkers to talk about prognosis. And I'll explain what this means. But basically, if you have certain biomarkers, then it means that you have amyloid in the brain. And the new definition of Alzheimer's disease means that if there is amyloid in the brain, then you have Alzheimer's disease. Again, some experts feel that just amyloid is not enough. You need tau in the brain, so you need a different biomarker. But again, all this is rapidly evolving. But I'll try and connect all this to clinical care. The core 2 biomarkers are different, where even if I have amyloid in the brain, how likely is it that my current memory problems are because of the elevated amyloid in the brain? So there'll be a different set of biomarkers that I'll be doing testing to guide the patients that your memory problems are because of Alzheimer's disease in the brain. Next slide. So what are the core 1 biomarkers that are currently available? So now, for many years, we have been able to do amyloid PET scan, positron emission tomography, approved by the FDA. Unfortunately, we don't have it in Boise or Idaho. At our memory center, we send patients often to Salt Lake City. We work closely with a neurologist there, and some of my patients go to Seattle. We at St. Al's have done CSF biomarkers. So again, it's FDA approved, where you test CSF to look for amyloid, A beta 42. That would go down as you develop Alzheimer's disease. and tau biomarkers, so say phospho-tau 217, that would go up. It's elevated in the CSF. So if you see those findings, then the test results would come back, say positive, and that would indicate that you have Alzheimer's disease and your memory problems are quite likely because of the Alzheimer's disease in the brain. Now, very recently, just a few months ago, the FDA approved the first blood-based biomarker, plasma biomarker called Lumipulse G, uh, and we can now do a blood test and say that if the blood test is, say, positive, it means that you have amyloid in the brain. And that means that if I'm already suspecting that you have Alzheimer's dementia, then if I do the plasma biomarker and if it is positive, then I can say with greater confidence that your memory problems are because of Alzheimer's dementia. Now, it's important to remember that greater confidence, so we are still not at 100%, but we are very close to 100%. So there are false positives and false negatives of all these biomarkers, amyloid PET, CSF, as well as plasma biomarkers. So what does that mean? So around 2.7% or say 3% are, you can have false negative, which means that the plasma biomarker test says that you don't have Alzheimer's disease in the brain, but it's a false negative. Again, if you have positive plasma biomarkers, say elevated phospho-tau 217, you can have, say, around 8% false positive, which means that even though it's positive, your your memory problems might not be because of the Alzheimer's disease, and it might be the elevation of phospho-tau may also be because of some other reasons rather than amyloid in the brain. So again, things are very, very sophisticated. So we need to be very careful when we start doing these tests. Next slide. Again, if you have any questions, please put that in the chat. Dr. Coons, our director of our memory center, will be happy to answer those questions also, because I have many slides, so I'm not sure at the end how much time will remain. So moving on to core 2 biomarkers. So currently they are in research setting, but all this is moving so fast, this biomarker testing, that I won't be surprised if these tests are available within the next year. Now, remember, tau PET is already available, but in the research setting, we don't do it in clinical setting. And again, there are specific different biomarkers than the biomarkers I mentioned before. So there is now p-tau 217, which is not mentioned on the slide. And then there is this MTBR tau 243, microtubule binding site, receptor site. So again, we can do, so let's say this grandson says, so, all right, so my dad, what if he has a start of early Alzheimer's disease? You guys have assessed him and you've done a Montreal cognitive assessment. He scored 28, but you said that he's very intelligent. And so even though the test was positive, we should do neuropsychological testing to identify mild cognitive impairment. It's a stage before dementia, but it's still abnormal decline in memory functioning and thinking functioning. So you've done a neuropsychological testing, you referred him for that. The results came back that he has mild cognitive impairment. Then you've done a brain scan, it shows hippocampal atrophy. So your clinical diagnosis is Alzheimer's disease. You've done plasma biomarker, p-tau 217. It's elevated. So you say that this is quite likely Alzheimer's disease. But you said that there could be other reasons for my dad's memory problem. It doesn't have to be Alzheimer's. So how can we be sure? Then I would say that if in the research setting, if we did tau PET in your father, and it showed evidence of tau developing, then I can say with even greater confidence that the memory problems are because of Alzheimer's disease. And if we don't do anything, then this is likely to progress. Again, in the future, we won't have to do tau PET. It's very costly, not available. And quite likely there'll be blood-based or plasma biomarkers like this MTBR tau 243, or totally something totally different. And I would do that test, and I would say that since this test is positive, it means that even though your father may have, say, obstructive sleep apnea, depression, that could cause memory problems, because the biomarker was positive, it's very likely that your father has Alzheimer's disease, which is progressive, and currently there is no cure. Next slide. Again, this is just educational. In the future, we'll be doing more biomarkers. Uh, Currently, we don't do neurofilament light NFL as a plasma biomarker, but research has shown that if, let's say, you have frontotemporal dementia and it manifests as some psychiatric disorders, and you're not sure, in the future, we might do some blood-based biomarkers like the NFL to show that your psychiatric problems are because actually for frontotemporal dementia, because there is neurodegeneration going on, and this is not a primary psychiatric illness. Currently, we even do FDG PET, fluorodeoxyglucose PET scan. It's a functional scan checking glucose uptake to differentiate between frontotemporal dementia and Alzheimer's disease dementia. Now, these differences are important because if I want the patient to, if the patient wants to try the new drug that I'll be discussing, the disease modifying drug, say lecanemab, then they need to have Alzheimer's dementia and not frontotemporal dementia or Lewy body dementia. Again, there is a lot of neuroinflammation going on in the brain. So in the future, we'll be doing other biomarkers like glial fibrillary acidic protein. Again, we currently do brain scans. MRI is better to look for small evidence of vascular disease or bigger strokes, white matter hyperintensity, WMH. And then again, we can't forget Lewy body disease and Parkinson's disease, where it's a different protein accumulating in the brain and destroying the brain cells and synapses, alpha-synuclein. And in the future, we might do plasma assays of this protein. Currently, we can do biopsies of skin, believe it or not, to diagnose alpha-synucleinopathy that is seen in people with Parkinson's disease and Lewy body disease. But again, there are a lot of false negatives. So we need to keep all this in mind, and a specialist needs to guide you. Next slide. So again, we need to really have clinical judgment, because most of the research is in white population, maybe 90%. We'll get new studies that show that now we have more racially diverse population, but until that happens, we need to be cautious. And again, as I said, there could be false positives of elevated, say, phospho-tau 217. That's currently the most common test done across the country. The number of people who are doing this test has gone up, not only in specialist settings like our memory centers, so geriatricians, neurologists, geriatric psychiatrists, but now many primary care physicians have started to order this phospho-tau test. So we have to be careful again that there could be false positives if you have, say, kidney function impairment and so forth. Next slide. Also, we need to remind patients that on average, 10% of individuals in our population who are cognitively normal will show amyloid in the brain, and it will come up as plasma phospho-tau positive. So again, it just means that there is amyloid in the brain. That doesn't mean that you will develop cognitive decline 100%. Again, if you go up to age 85, then 33% will have amyloid in the brain. And again, they'll be cognitively normal. So we need to realize that most of them will not develop dementia. Next slide. We need to also remind our patients that there are now centenarians, people 100 years and older, who can have Alzheimer's disease neuropathology in the brain. So they have amyloid plaques, neurofibrillary tangles. but they've never had any clinical symptoms of mild cognitive impairment or dementia. So they've not had cognitive decline, they don't have memory problems, they don't have language problems, word finding difficulties, except what is normal for age. So Dr. Tom Pearls, who's like the world expert on centenarians research and cognitive health, he says that these individuals are resilient. And there are now centenarians where there is no Alzheimer's disease neuropathology at all. There's no amyloid plaques, no neurofibrillary tangle. So we need to remind ourselves that Alzheimer's disease neuropathology is not inevitable as you age. Next slide. So again, we need to be very careful not to start doing these tests and to follow guidelines. Now, all these guidelines will also change quickly, but at this point, uh, some experts have said that maybe, you know, we can triage individuals who have, say, cognitive decline, then they have done assessment, they've gone through a thorough assessment, and they've been found to have no reversible cause of this cognitive decline, like obstructive sleep apnea, depression, thyroid dysfunction, vitamin deficiency, normal pressure hydrocephalus, and so forth. And then one might do plasma phospho-tau. And again, if it's negative, then we don't have to worry about Alzheimer's disease because, as I mentioned, false negative is a very small amount. So then we can reassure them that you don't have Alzheimer's disease, you still need help for your cognitive decline. But if the plasma phospho-tau is positive, then they should be referred to a specialist clinic like our memory center, and we can help the patients and the family members really understand what's going on. Next slide. So again, if I diagnose somebody as Alzheimer's disease now, I need to have a biomarker evidence before I say that you have mild cognitive impairment due to Alzheimer's disease, which I mentioned is a stage before dementia, or that you have mild dementia due to Alzheimer's disease. So in the case that I talked about, the grandfather has moderate stage, probably mixed dementia, but his father may have mild cognitive impairment, Alzheimer's disease, since he meets all the criteria, including positive biomarker. And then I could talk to him about treatment options. Next slide. So again, as I mentioned, these are not FDA approved at this point. The other biomarkers in the future, we might be doing this to help us understand which individuals may have better response to disease modifying drugs and which would not be non-responders. So, and I'll come to the drugs in a minute. Next slide. As I mentioned again, this test is the first FDA approved test, and we expect more tests to come. And it comes up as positive, indeterminate, or negative. And again, we need experts to help the patients understand what all this means. Next slide. So again, as I said, we need to follow clinical guidelines. So if this grandson says, you know what, I'm just going to do a DIY, do it yourself testing, direct to consumer testing, and I would say, no, please don't do it because we can't interpret the results. All the studies have been done for these biomarkers in specialist settings. So this Lumipulse G, which is approved by the FDA, in their package insert of the test, it clearly states that the test should be done in specialist settings, not in primary care. When we get more research to tell whether this can be applicable to primary care, that's when we can start doing it, but not as yet. The reason is because the false positives and false negatives will be radically different in primary care population, which is very different population than the population who comes to the memory center for cognitive assessment, diagnosis, and treatment. The prevalence of dementia matters, as we've seen that with COVID testing. If the prevalence of a disease can influence false positives and false negatives. So in the memory clinic, the prevalence of dementia is very high, like 60, 62%. So in that case, these biomarker tests have been studied and we can do it in an appropriate patient, but not as yet in primary care settings. And again, we'll have patients who will do it on their own. Then it's important that they come to us in our memory center so that we can help them interpret the results, provide education, guidance, counseling, and so forth. Next slide. So currently, these tests should not be done in an asymptomatic individual or individual with subjective cognitive impairment. So say the grandson, he doesn't have any memory problems. I would say we should not be doing the test in you. His father has mild cognitive impairment, but say hypothetically he had subjective cognitive decline, but there was no objective evidence of cognitive impairment. So his MoCA score was say 30 out of 30, Montreal Cognitive Assessment, office-based paper and pencil test score. And I referred him to neuropsychologist. The test results came back that there is no mild cognitive impairment, no dementia. Then the father has subjective cognitive decline. I would not be doing plasma biomarker testing in him, the father. But again, the father had mild cognitive impairment. And so in that case, it was appropriate to do plasma biomarker testing. Next slide. Again, we need to follow guidelines. We have guidelines telling us what to do. The problem is that the dementia care, the diagnosis takes so much time that it's hard for primary care physicians to really do all these components of diagnostic process. The key message today is that the biomarker testing is in the section of advanced diagnostic testing. So it needs to come way down in the diagnostic process. But unfortunately, even currently in our country, there are many primary care clinics where the person comes, they report memory problems. The primary care providers do not do any cognitive testing like Montreal Cognitive Assessment. And they might order plasma biomarkers like this phospho-tau 217, and they will not know how to interpret that. So that's a worry, and we should educate our patients not to go through that route. In the future, there'll be all kinds of telemedicine startups coming up who will mail you a kit, $500, and you can do biomarker testing on your own, and then you'll have a telemedicine visit with a neurologist who will explain to you the results. And if they are positive, then the neurologist will guide. Again, I myself worry. Dr. Coons and I have talked. Dr. Coons also worries about all these other forces that are coming on to do these testings very quickly. The main reason all this is developing is because a lot of these patients then will be referred for disease modifying drugs, which I'll be mentioning in a minute or so. And they are very costly. So there is a lot of money to be made in some settings. Next slide. So take home point, there is no single standalone test to diagnose Alzheimer's today. So if somebody says, I heard there is an Alzheimer's test. So you say, nope, there is no such single standalone test. The test that we talk about, the blood-based biomarker, is one piece in the diagnostic process, and it has to come much later. So it's best, let's say if I'm the primary care physician, I would say it's best if I don't order it, but I can refer you to specialists who can guide you. And again, if the tests were done, it's best to involve a specialist to interpret the results. Next slide. So Dr. Nathaniel Chen, he's the first author, and Dr. Erickson wrote a superb article guiding primary care physicians and providers in how to navigate this challenging biomarker and monoclonal antibodies, so MABs, monoclonal antibodies, anti-amyloid therapies treatment. So again, Dr. Chen says that if, say, the patient has memory decline, but they also have depression, they are on medications that have anticholinergic properties. So the anticholinergic drugs can themselves cause memory problems. Say they were on a drug called paroxetine, Paxil, as an antidepressant. they were on oxybutynin for urinary problems, then those medicines can cause memory problems. Let's say in addition they had obstructive sleep apnea, then it's important for us to say that, listen, just because the test was positive doesn't mean that these problems are not causing your memory problems. And let's address depression. Let's deprescribe anticholinergic medicines. Let's make sure you're optimizing treatment for obstructive sleep apnea. And then let's the patient says, yes, 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 but I'm worried about Alzheimer's disease and I want to be on this monoclonal antibody therapy that has just been approved by the FDA. Then you explain that that requires a very separate evaluation. What does that mean? It means that there are inclusion criteria. You have to have Alzheimer's disease that is biomarker positive. And again, to be eligible for these therapies, a blood test won't be enough. In the future, maybe, but currently you'll have to have amyloid PET or CSF positive. And you will have to also not meet any exclusion criteria. Like if your brain scan shows, 4 or more microhemorrhages, if you're on anticoagulants for atrial fibrillation, then you will meet the exclusion criteria. You will not be eligible. So it's a very complex process. So the bottom line is that majority of the individuals uh, do not land up in that direction of getting monoclonal antibodies for a variety of reasons. One of them is they don't meet the inclusion and exclusion criteria. Next slide. So let's now talk about the disease modifying therapies, although uh, just a quick line or two on symptomatic therapy. So FDA has now approved a drug called brexpiprazole. The brand name is Rexulti for treatment of agitation associated with Alzheimer's dementia. Again, it's a very high risk drug. I would say let's focus on non-drug interventions and minimize the use of brexpiprazole or antipsychotics. Uh, in the patient that I had, the grandfather who came for actual management of agitation and insomnia, I explained that even though there are therapies that are FDA approved, like the suvorexant, Belsomra for insomnia due to Alzheimer's disease, I think we should try and manage it with non-drug interventions. These drugs can increase the risk of falls and have all kinds of other risks. And so we need to be very careful. So I'll spend more time on these disease modifying therapies. Next slide. So we have 2 drugs now that are FDA approved in US for treatment of early Alzheimer's disease. All right. So early Alzheimer's is mild cognitive impairment due to Alzheimer's disease or mild dementia due to Alzheimer's disease. So that's early Alzheimer's. If you have moderate stage Alzheimer's dementia, FDA has not approved any treatment for that. These are disease modifying treatments, which means that they slow down the cognitive and functional decline. They are not curative. Currently, we have no cure for Alzheimer's disease. So we have to explain this to the patients who have read a lot about this and are eager to do everything they can to slow down the disease process or even sort of arrest it in its course. We need to also realize that not everybody has approved these drugs. Like in Europe, the European Medicines Agency felt that the risks of donanemab, the second drug, were too high. Mainly the risks of brain bleeds were too high, and they felt the benefits were just too small. And so they did not approve that. Now, donanemab has come out with a slower titration, which has less risk of these brain bleeds. So there's a good chance I can imagine them reapplying and they might get approval. But lecanemab got approval first. Now, these are monoclonal anti-amyloid antibodies. So these have to be given through intravenous infusion. So for lecanemab, it's every 2 weeks for 18 months. After that, the FDA has just approved a subcutaneous version that can be given once a week at home. It just got approved. We don't have data beyond 18 months for these monoclonal antibody treatment. Donanemab, as I mentioned, it has a higher risk of brain bleeds than lecanemab, but it is given once a month compared to once every 2 weeks of intravenous infusion. So the burden of care is very high, and not all patients and family members can really uh, adhere to all these rigorous treatments. And again, we don't have that available in Boise or in Idaho. We have to send them to Salt Lake City, uh, at least for initial assessment, and then they can get these treatments through our intravenous infusions over here. And again, there are these are high risk drugs, so we need to do brain scans, MRIs frequently to monitor for brain bleeds and brain swelling. Uh, so the cost also is a huge issue. The drugs themselves cost anywhere from $26,000 a year to $30,000 a year. And then if you add MRI and all the others, the cost could go up to $90,000 per year per person. Next slide. So what is the real world experience of lecanemab? So again, a lot of research comes from Washington University in St. Louis. And these studies are good for us to know that although research settings showed that patients are at risk for what is called ARIA, amyloid related imaging abnormalities. So that's the reason we are doing MRI of the brain after we start before treatment starting, and periodically after that to look for brain swelling and brain bleeds. And again, many of them are asymptomatic. So you might find the MRI to be abnormal, like they show brain bleeds or brain swelling, but there is no clinical manifestation. Even if there is no clinical manifestation, if they show abnormalities in the brain in the MRI, then you have to stop the infusion. Otherwise, it'll get worse. And some individuals are at higher risk. Let's say if you have ApoE4 gene, you are at much higher risk of ARIA, amyloid related imaging abnormality. You're also at higher risk of symptomatic ARIA. So an example of symptoms could be all the symptoms that you have seen in transient ischemic attack or stroke. So a patient may suddenly stop uh, having normal speech, or they might have sudden visual deficits. So let's say that when this grandson said, so maybe my dad is interested in this, what are the risks? I would explain that your dad needs to be closely monitored if he develops sudden uh, severe headache or sudden loss of speech or sudden weakness or sudden vision loss. You have to tell us right away. He has to go to the emergency department, make sure that he doesn't, the neurologist and the emergency team know that he's on this drug so that we do not give him the standard treatment for stroke, which is TPA, because you can get bleeding from that intervention. The treatment is more to just monitor, observe. Sometimes you might use steroids. Basically, you need a neurologist to guide you through the symptomatic area management. Now, as this study shows, people with mild cognitive impairment, like this father of this grandson, the chance of symptomatic area are really low, 1.8%. Now, again, we need more studies to show this, but a lot of researchers are saying that if we start the treatment very early on, like in the mild cognitive impairment stage, then the results will be much more dramatic. So again, we need to just keep that in mind. Again, there were two patients with severe clinical symptoms. I've had cases where people have developed strokes. There are rare reports of death. So these are not benign drugs. Next slide.
Dr. Desai,
Yeah,
sorry, on that previous slide, I think maybe you just had a typo there. Could you go back one slide, Kelly? That 27% of patients with mild dementia had asymptomatic ARIA.
yeah, you're right. So 27% asymptomatic area. Thank you. So as I mentioned, brexpiprazole is an antipsychotic, high-risk drug, best to minimize its use as much as is possible. Next slide. Again, insomnia is very common in dementia patients, best to manage it with non-drug interventions. We'll have a whole different talk with Dr. Coons on palliative care, management of moderate to severe dementias. And again, we can discuss more of these treatments at that time. Next slide. Now, this is another big deal that has happened, and Dr. Kuntz and I and everybody in the memory center world are very happy that finally we have a comprehensive treatment plan that is funded by Medicare, which can provide care management, care coordination, more support for caregivers, education, respite services. Now, this is an experiment, so it's an 8-year experiment. We've finished 1 year, we've started a second year, and there are all kinds of different memory centers and clinics across the country who are doing this guide model. So to me, this is a huge treatment advance from before. Next slide. Now, at a memory center, we already do this. We provide team-based care. We address the needs of family members who are going through a lot of caregiver stress, caregiver grief, caregiver burden routinely. And this new model provides higher payments for this more complex care. So again, we'll see and hear more of such innovative models. Next slide. So this is the final, almost the final slide. So let me conclude. So this is Dr. Atul Gawande. He's a surgeon, brilliant writer in his book, Being Mortal, Medicine and What Matters in the End. This is what he says. We are caught in a transitional phase. However miserable the old system has been, we are all experts at it. So regarding dementia, the old system is that we don't talk about modifiable risk factors for dementia. We don't spend time educating individuals about improving brain health program. We don't take time to do thorough assessments. We don't take time to address family members' concerns. And we don't educate in best appropriate use of all these complex biomarker testing. So we are all expert in all these old systems. We know the dance moves, which is fast medicine. With this new way, which I've shared today, slow medicine, having a very measured, comprehensive approach in which we together try to figure out how to face mortality, which means how to face our own risk of dementia, our family members' risk of dementia, and preserve the fiber of a meaningful life with its loyalties and individuality. We are plodding novices. We are just starting, really. I believe at Memory Center, we've been ahead of the game. We've been doing this for several years now, but as a society, we are just starting. We are plodding novices. We are going through a societal learning curve, one person at a time. Next slide. So thank you. We'll remove the slides and we, meaning Dr. Kuntz and I, will be happy to take questions. Namaste. Thank you. You can put it in the chat or just unmute yourself. This is all low key. Well, while we're waiting, Dr. Kuntz, just share more about Brain Health Symposium.
Hi, Nancy Coyce, can you hear me?
Yeah, go ahead.
I just wanted to thank you for a wonderful presentation. Thank you so much.